The main theme of the conference was patient empowerment. The attendees interacted closely with experts and other knowledgeable patients through support groups, question and answer sessions, and educational breakfasts. This annual event embodies the belief that empowering the patient to partner with his medical professional is key to optimal care, and I believe that. The first thing, usually when you get a prognosis, you have to get a biopsy. Now I'm showing the biopsy needles in the prostate. The prostate is the round object. The urethra is always going through the prostate. But there's a primary cancer and a secondary cancer. And as you can see, the needles don't always hit the cancer because they're random. They put them in with the ultrasound transducer on the left. He uses that to get it started. But the interesting thing, a patient-friendly examination which drastically reduces the need for biopsies and may even eliminate them altogether has been developed at Eindhoven University of Technology together with an academic medical center in Amsterdam. To make this visible, Dr. Michi used the fact that tumor tissue produces large numbers of small blood vessels with a characteristic pattern. Patients are given a single injection of a contrast medium containing tiny bubbles, can you believe it? Which are seen by the ultrasound scanner right down to the smallest blood vessels. Using advanced image analysis techniques that can recognize the characteristic blood vessel pattern in the tumors, the computer then generates an image showing where the tumor is. The new method can be introduced quite simply because no new equipment is required. The existing ultrasound scanners, which the hospitals already have, can continue to be used. So it's possible that you don't have to have a biopsy. Now, one of the interesting things I found at the conference, these American patients were having biopsies yearly. Every year they would have a biopsy. And some of them said they had to be put under because they hurt so much. Low-risk prostate cancer for patients have a T1, T2 tumors, PSA of less than 10, and a Gleason score of less or equal to 6. And intermediate risk prostate cancer, which most people have, has a T2 tumor, a Gleason score of 7, and a PSA of 10 to 20. The high-risk prostate cancer has T3 tumors, a PSA of greater than 20, and a Gleason score of 8 to 10. Now, for men with low-risk cancer, the decision is simple: active surveillance. For men with intermediate risk cancer, the decision is complicated because there are so many options. Decisions about treatment are based on the risk of side effects. Can you believe that? Men with high-risk cancer should know that radiation combined with TIP is superior to either radiation alone or TIP alone. TIP is testosterone inactivating pharmaceuticals. Eligard is one example. Lupron is another. Next. It seems that 2 scanners at once seem to be the future for cancer imaging. This is a list of scanners that are being used. The CT scanner, computer tomography. It's the one where you get slices in the body. You see slices. A PET scan and a CT is a good cancer scanning system. Bone scanners, MRIs, and carbon-11 choline PET scanners are now being tested. There are some carbon-11 acetate PET scanners available in the United States. I don't think they're here in Canada. Carbon-11 is like carbon-14. You know what carbon-14 is? It has a half-life of 5,000 years. Carbon-11 has a half-life of 20 minutes. So you can imagine that it has to be produced just before it goes on the scanner. I found a couple discussions on the website, which I'd like to read, and it'll answer some of your questions. Hi, Doc. It has been 3 or 4 years since I had an MRI, and I have never had a PET scan. I asked my oncologist about this, and he felt neither tests were warranted at this time. So far, I have only a high PSA score to show that I might have cancer, but they have never been able to locate it. It is rather simplistic, but if they can't find it, then they haven't proved I have cancer. From what I gather, the PSA score alone is not a definitive answer. Not sure if an MRI is needed, but feel it might help me understand what's going on in my body if they found something. Hi, Howard. It sounds like you've never had a biopsy either, along with any definitive imaging. A high PSA score does not prove you have cancer. Since your PSA has dropped significantly, that would push it further away from cancer. You mentioned horrendous side effects from your PSA dropping. I've not heard of a dropping PSA having side effects. Are you taking some kind of hormone therapy? Howard. Yes, I am on hormone therapy, Eligard and Casodex. I will be on Eligard for the foreseeable future. I am a recurrent biochemical failure. I am also taking progesterone for hot flashes. I've had 2 biopsies early in my treatment. The first found cancer in 2 cores, while the second found nothing, leading doctors to believe the cancer had migrated. And here's another one. Hi, Doc. I understand that choline is a difficult compound and that deteriorates rapidly. If carbon-11 choline PET scan is so incredibly detailed to identify even minute traces of cancer any place in the body, how come it has not been installed at a number of locations in the U.S. or outside of the Mayo Clinic? Any other place in the entire world where they have working C11 choline PET scan machines? Hello, James. As I understand it, carbon-11 isotope choline was approved for use at only Mayo Clinic, so I am unaware of any other clinic using choline. I also understand that the machines are outrageously expensive. C11 acetate, on the other hand, yields, from what study shows, that it is equally effective and is available outside the Mayo Clinic. The principles and results are the same, but the contrasting agents are different. Dr. Fabio Almeida is a leader in this field and is located in the Arizona Molecular Imaging Center. You might want to investigate the carbon-11 acetate PET scanner. Now, these are pictures of the C11 choline PET scan, CT scan. The CT scan is on the right. You know, the sliced, that's a slice through the body. And the yellow is the cancer that they found in the hips. This is a picture. The top is the head, and the cancer is in the liver, maybe, and that's the testes at the bottom. But this is what the C11 choline PET scan will produce. Prostate brachytherapy, seed implantation as a treatment for early localized prostate cancer, is as effective as other recommended treatments, but has fewer serious side effects. Since it does not involve major surgery, brachytherapy may be preferred by patients because it preserves their quality of life, notably their sex life and urinary control, and limits their time in hospital after the procedure, allowing them to return quickly to their everyday lives. So I'll show you something about brachytherapy next. Now, the illustration on the right shows how the seeds are put into the prostate gland. Over here, you can see the little green seeds. Those are the little seeds. They put 70 to 150 of these little seeds in your prostate gland. But you can see, in this case, only 3 of them have hit the cancer. Now here's the types of therapy. You might know the brand name or the generic name, and you can see the kind of hormone therapy. Those are all hormone therapies. If you're taking some of those, you'll know about it. The next is chemotherapy. There's a bunch of chemotherapies. A lot of people start with hormone therapy, and they go on to chemotherapy. But what was new and what is new is the immunotherapy and the genomic therapy that's going on today as experiments. What's immunotherapy? Immunotherapy to treat prostate cancer is a new and emerging field. This method involves the introduction of a patient's immune cells to a protein that causes the body to react with an immune response to fight the disease. The FDA in the United States has approved one therapeutic vaccine, Provenge, and others are currently being tested in men with advanced prostate cancer. So Provenge is a personalized treatment that takes your immune cells from your blood and reprograms them to attack your advanced metastasized prostate cancer. Blood will be drawn from your body. Technicians collect some immune cells and return the rest of the cells and blood back to your body. Therapy with Provenge can be completed in about a month with only 6 appointments. 3 Provenge treatments cost $6,000. Now, what is genomic therapy? Genomic therapy. Genomic therapy determines the genomic prostate scores. They call it the GPS. They analyze 17 genes in cancer tissues taken by biopsy in the prostate gland. Oncotype DX is the name of the genomic therapy procedure. Oncotype DX results are based on a clinical risk assessment based on a combination of PSA, Gleason score, and clinical stage ranging from 0 to 100. Genomic prostate scores predict the likelihood of favorable pathological results of cancer. So it doesn't do anything, but it helps you determine what the future is. The patient report helps in deciding whether to perform active surveillance or immediate therapy. One treatment costs $60,000 US. There's the one on the lower left is Kelly, who is the leader of the women's group in Calgary. We were all running around. We didn't very well see each other very often like this. Thank you.